Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from June the 12th to June the 19th. Here's the overview. On June 15th, European Society of Cardiology published clinical consensus statement on antithrombotic therapy for ACS patients post-PCI. It advocates moving away from the default 12-month DAPT toward personalized strategies based on individual bleeding and ischemic risk assessment. Since high bleeding risk is more prevalent than high ischemic risk, 20 to 40% versus 5 to 10% of patients, while risks overlap, bleeding risk should be prioritized over ischemic risk when choosing DAPT regimen. DAPT abbreviation strategies include 3 to 6 months DAPT followed by aspirin monotherapy, or 1 to 3 months DAPT followed by P2Y12 inhibitor monotherapy, which can reduce major bleeding without increasing ischemic risk. Ticagrelor is preferred for monotherapy after 1 to 3 months DAPT, except for high bleeding risk patients. While clopidogrel may be more appropriate in high bleeding risk patients, unguided de-escalation, or patients without CYP2C19 loss of function alleles to reduce bleeding without increased ischemic risk. No ideal scoring systems exist to balance ischemic and bleeding risks for now. Considerations in special populations include for East Asian patients, DAPT de-escalation reduces bleeding without safety concerns, while for Caucasian patients, reduction in DAPT intensity may incur ischemic penalty. Extended therapy options for selected high ischemic risk patients without high bleeding risk include prolonged DAPT with aspirin plus ticagrelor, 16 mg BID, reduces major adverse cardiovascular events. Aspirin plus very low-dose rivaroxaban, 2.5 mg BID, reduces cardiovascular death but increases major bleeding fourfold. On June 16th, National Comprehensive Cancer Network published Testicular Cancer Guideline version 2.2026. The most significant updates involve the removal of pembrolizumab from the third-line systemic therapy options for metastatic germ cell tumors. While pembrolizumab was removed, the guidelines now explicitly include a statement that pan-cancer tumor agnostic treatments can be considered for patients with actionable mutations within the third-line therapy sections. The guidance on molecular testing has also been updated to specify that it should include both next-generation sequencing and immunohistochemistry testing. For stage 2A or 2B seminoma patients who undergo a nerve-sparing retroperitoneal lymph node dissection, the treatment options for those found to have pathological stage N1 to 3 disease have been expanded. Adjuvant chemotherapy based on data from non-seminoma, including 2 cycles of etoposide, cisplatin, or EP, is now included as an option. For patients with a partial response to primary treatment, residual masses with abnormal AFP and/or beta-HCG levels, the guidelines now include surgery in highly select cases as a management option for markers are elevated and rising or elevated but stable. A new footnote on ANSEM4 clarifies that patients with sub-centimeter residual nodes who had teratoma or ehjacc tumor in their primary tumor may be at high risk of teratoma or viable germ cell elements in the post-chemotherapy residual nodes. The panel continues to recommend staging tumors with discontinuous invasion of the spermatic cord as pathologic stage T3, high-risk stage 1, and not as M1 stage 3, as recommended by the ehjacc 8th edition to avoid potential overtreatment. For a follow-up, the recommended timing for repeat imaging for persistently positive residual mass has been adjusted, with an option to wait an additional 8 to 12 weeks, changed from 6 to 12 weeks. On June 17th, the American Gastroenterological Association, or AGA, updated the original 2017 Power White Paper with comprehensive guidance on implementing multidisciplinary obesity care, incorporating major advances in anti-obesity medications, endoscopic bariatric therapies, and surgical interventions. Key updates since 2017 includes: first, new definition of obesity. The Lancet Commission in 2025 introduced clinical obesity as a chronic systemic illness characterized by tissue or organ dysfunction due to excess adiposity. BMI alone is now considered suboptimal. Recommended assessments include waist circumference, adiposity percentage, or BMI plus at least one anthropometric criterion. 2. GLP-1 receptor agonists, semaglutide and tirzepatide, have transformed obesity management. They can consistently achieve more than 10% total body weight loss and improve obesity-related conditions, such as diabetes, hypertension, obstructive sleep apnea, and metabolic dysfunction-associated steatotic liver disease. Key challenges include high discontinuation rates, weight regain upon discontinuation, cost and access issues, GI adverse events, and not cost-effective compared to first-generation anti-obesity medications. Third, emerging precision obesity care, including genetic testing, can predict response to specific medications, and machine learning-assisted gene risk scores may enable personalized medication selection. Fourth, endoscopic, bariatric, and metabolic therapies has been FDA-approved options for BMI more than 30 kilograms per square meter. Intragastric balloons achieves 7 to 15% total body weight loss at 12 months. Endoscopic sleeve gastroplasty achieves 13.6% total body weight loss at 52 weeks in MERIT trial. Maintained more than 80% total body weight loss over 24 months, and retrospective data shows 15.9% total body weight loss at 5 years, with serious adverse events rate of 2%. Fifth, bariatric surgery remains to be gold standard. Long-term durability shows 25 to 40% of total body weight loss depending on procedure. Mortality reduction shows 38% reduction in 5-year mortality versus no surgery, and perioperative mortality is 0.1%, which is lower than hernia repair or cholecystectomy. Indications have been expanded since 2022 ASMBS IFSO guidelines. BMI more than 35 regardless of comorbidities, BMI 30 to 34.9 with type 2 diabetes, and BMI 30 to 34.9 should be considered. Efficacies in most common procedures show sleeve gastrectomy shows 25 to 30% total body weight loss, Roux-en-Y gastric bypass is 30 to 35%, and duodenal switch is 40% total body weight loss. 6. Combination therapy GLP-1 receptor agonists plus endoscopic sleeve gastroplasty yields superior outcomes. ESG plus liraglutide achieves 24.7% total body weight loss versus ESG alone, which shows synergistic action between medications and procedures. 7th, as for other concerns, cost and access remain to be major barriers. Advocacy is needed for coverage of proper treatment. Move on to FDA news. On June the 17th, the US FDA has approved first oral carbapenem therapy, EHjacc tablets, for the treatment of complicated urinary tract infections, including pyelonephritis, caused by several susceptible microorganisms in adults who have limited or no alternative oral treatment options. Efficacy was assessed in the intent to treat population as a composite of clinical cure, resolution of signs and symptoms of infection, and microbiological response, reduction of baseline pathogens at a follow-up visit. The composite response rates show that EHjacc's effectiveness was comparable to imipenem cilastatin. The most common side effects are diarrhea, headache, nausea, abdominal pain, increased liver enzymes, and C. diff infection. Patients with allergic reactions to eutepsi or other beta-lactam antibacterials should not take eutepsi, nor should patients with primary or secondary carnitine deficiency or inborn metabolism errors that may result in clinically significant carnitine deficiency. That's all for today. Enjoy your weekend. See you next week.